Welcome to Sir Henry Fraser, His Life in Focus. I'm Miles Eversley. Thanks for joining us. In our last episode, Sir Henry recounted a number of success stories he enjoyed while working at our hospital. He continues those wonderful stories as he speaks fondly of the pleasures of patient care.
Looking after patients is extremely satisfying. You know, nowadays we do have a problem with doctors who choose a career because being a doctor seems to be a good thing to do. In the old days, the challenges and the long period of training to become a doctor meant that people had to feel really dedicated about it. And I've always been pleased when I came across a student who told me on first meeting them or soon after that they chose to be a doctor because when they were 5 years old, Granny was extremely ill and suffering terribly in pain. And they thought, when I grow up, I'm going to be a doctor. I think that is a great motivation which has motivated a lot of people and provided the dedication that is necessary for a career that is dedicated to really helping people. My hero, my own hero, of course, was Dr. Harry Bailey, because Dr. Harry Bailey was a man who loved his medicine. He was a great diagnostician, and he reputedly saved my life at the age of 9 when I had paratyphoid fever, and a series of 3 general practitioners couldn't solve the problem, and he solved it immediately. And of course, I worship him for the rest of his short life, because he died at the age of 50, sadly, because he was an interesting man I must talk about, because he didn't understand prevention, and he had smoked all of his adult life. He was a fantastic athlete. He was an athletic blue at Cambridge University when he went there in his tripos before he did his clinical medicine in London. And he was a great athlete, but as he came back to Barbados and settled into a married life with his brilliant wife and probably a wonderful cook, and sitting in a chair making diagnoses or working at the bench, he didn't continue in sport, and he got fat. So he was large and he smoked apparently quite a lot. And nobody knew in the 1950s that cigarette smoking was a death knell. They didn't know that cigarettes are really cancer sticks, and they didn't know that cigarettes produced heart attacks and heart disease and plaques on the heart and all of that. So as I said in my biography of Harry Bailey, he didn't just ride the wave, he made the wave. He did all the things that he envisaged. He got them done. And hence the diagnostic clinic that we still have today in a slightly different form, in the Bayview Hospital, which grew out of that. But I worshipped Harry Bailey, and I always wanted to be as good a doctor as Harry Bailey. But I had problems, I had challenges. I hated the sight of needles and I hated the sight of blood. So when I went into medical school, as I think I said before, I wasn't sure whether I could survive the whole thing and accommodate myself to sick people, needles and blood. And that's why I went off to Britain to do my research degree, the physiology degree that gave me a very great insight into doing research subsequently. But by that time I matured and I enjoyed every day of medicine, and it's a wonderful, wonderful experience, especially when you practice as a specialist and a doctor who you trust and who trusts you sends a patient that he's having difficulty with, and you can either make the diagnosis or solve the best approach to their treatment. But that's the one-to-one medical side. And of course, medicine consists of curing on the one hand and preventing, if you can, on the other hand. Now, in busy medical practices, and this operates in our government services, this operates in our overburdened polyclinics, for example, because although we've had this wonderful example of polyclinics under different regimes, starting with a small number and then expanding them so that we have one in each parish virtually, we have a problem with the number of patients who want to be seen. So it's difficult for a doctor who is having to see a patient every 10 minutes perhaps to spend 10 minutes counseling that patient about physical activity about diet, giving nutritional advice and so on. And we don't have enough nutritionists to give the advice. We don't have exercise therapists. We cannot do as in Britain. We cannot write a prescription for the gym and say, off you go to Surfside. Here's your prescription. This is going to be covered by the National Health Service. We cannot do that. And so it's much easier for a doctor to make a diagnosis as quickly as possible, give a few words of advice, write a prescription, and off the patient goes to get the tablets from the pharmacy. And often he doesn't need tablets. He needs counseling. He needs physical activity. He needs to eat less. You know, I often say that our $800,000 food import bill, of which only a portion goes to the hotels for the tourists, that could be cut in half if most people in Barbados would cut their food intake in half. Because almost all of us eat far more than we need. And what has been shown in rats is that a sparse and more frugal diet prolongs life significantly. So overeating doesn't just provide the chronic diseases that shorten life. Even if overeating doesn't make people fat, it still shortens life. But the one-on-one patient care has been really, really satisfying. As I said, when I came home, there was no neurologist, there was no chest physician, there was no rheumatologist, there was no geriatrician, there was no gastroenterologist. So these were 5 areas that I had had some experience that I could work with. The fact that we were able to get a chest physician was a fantastic success in every way, because when the HIV/AIDS epidemic struck, the people presented almost always with chest problems, with pneumonia. And so it became very obvious that the person who could lead in the management of the AIDS treatment program was our chest physician, Dr. Timothy Roach. So he was a huge boon, and we were very, very fortunate in Barbados to have someone like Tim, who, with the support of infectious disease specialists like Professor Anne St. John, on the children's side, and later Dr. Kumar, we could manage the AIDS epidemic, the HIV/AIDS epidemic, very successfully. So it was terribly important to get those people in place. But until they came into place, until Dr. Corbin came home in 1984, 85, I think, I was the neurologist for 6 or 7 years. And I had great satisfaction out of treating patients with epilepsy. My outpatient clinic on a Friday afternoon often became nothing but patients with epilepsy. And sometimes a patient would have a seizure on the couch, and I was able to explain to the students exactly how to manage the situation when a patient is shaking and having a grand mal seizure. Not to panic, not to put a spoon in their mouth, which for some reason came across in Barbados. Well, putting a spoon in the mouth to stop the person biting their tongue meant that they often lost a tooth or two. And it's well documented that a spoon in the mouth is the worst thing, because a broken tooth then gets swallowed and you have a tooth in the lung and you get chronic lung disease. So these are the kinds of things that serendipitously could come across to the students when you had an interesting patient on your couch in the clinic. But there are so many cases that come to mind. I've mentioned Sir Branford Tate and the opportunity that Sir Branford Tate provided simply because we had a talk while he was on the physiotherapist's couch. I've had patients with migraine, for example, patients who had never had their migraine properly diagnosed or explained, because migraine is preventable. 90% of migraine can be prevented if people recognize that migraine is precipitated by changes in light and changes in diet and anxiety. Well, you can't always solve anxiety. Anxiety is a much more difficult problem to solve, but you can solve diet. Cheese and chocolate are the big enemies of people like myself who have migraine. And if people can avoid the cheese and the chocolate completely, often their migraine disappears. But other things that people do not realize are things like glare. The brilliant sunlight is a trigger for migraine, and flickering lights are a trigger for migraine and epilepsy. So people drive around in Barbados in our brilliant light, and they're not wearing shades. People are going walking, and I see them in the daytime walking the highway, and they're not wearing shades, but they're wearing glasses. And they could wear shades easily. And if you reduce the light intensity, television is another precipitant of migraine, and of epilepsy, the flashing, the varying of the light of a bright television screen, all of these things. And so I have walked down Broad Street and met a patient who would say to me, "Oh, Dr. Fraser, it's a miracle. I haven't had any headache for 3 weeks, you know." And that was extremely satisfying. And then there have been other patients who are really quite memorable. One of them was a very large gentleman, a very important gentleman in Barbados, a gentleman with huge connections and influence, a QC who weighed a great deal and who had an abnormal heart rhythm. Now, one of the family practitioners whom I knew extremely well couldn't reach the cardiologist that day, and so he called me and he said, "I have Mr. X in my clinic this morning and his heart is behaving in a very peculiar way. Could you possibly see him?" So I said, "Okay, I'll see him." So over to the clinic, Mr. X came. It happened to be the one half day a week when I saw private patients. So Mr. X came over to the clinic and I took a history and everything. Now, my wife and I had decided that we would have our clinical examination couches built by the very friendly carpenter that we knew. So we built exam couches to our specifications. And the way these couches were built, they had wooden planks, short wooden planks, right along the length of the couch, supported by the main frame of the couch. But those planks were not actually nailed or fixed into place. And to get onto the couch so that you can examine a patient's abdomen and heart at a comfortable level as a doctor without leaning forward and getting back pain, the couch is a little high, so the patient is asked to step onto a step and then sit on the couch. Well, this goodly gentleman, all 280 pounds of him, decided on getting onto the couch to demonstrate how fit he was. So instead of gently easing himself onto the couch, he literally jumped backwards onto the couch, throwing his legs up parallel to the couch, and down he went onto the floor as the planks gave way. They were loose, they all fell to the ground, and he fell to the ground with them. And being a QC, of course, Queen's Counsel, I thought to myself, this is my second year of living in Barbados and practicing medicine, I thought to myself immediately, there goes my career. There will be a report to the Medical Council and I will be taken off the medical register and that will be the end, and I will have to resort to painting in order to make a living. Well, my good friend, he picked himself up off the floor and he said to me, as the gentleman he was, he said, "Sorry about that. Shall we put the planks back and try again?" Which he did. So that, I think, was perhaps the highlight of the wrong kind of my entire medical career. And then there was someone else I wanted to talk about. The lady with complex partial seizures. Now, let me explain for a moment here, because most people think of epilepsy as what we call the grand mal seizure, when you are shaking all over the body like this and you are clenching your teeth. And sometimes you may foam at the mouth because the teeth are so clenched you salivate. And that's a grand mal seizure, the French word grand mal in English. And that's the big seizure, as it were. But there are many other types of seizures. And the type of seizure that is known as the complex partial seizure, or the temporal lobe seizure, because it originates in the lobe of the brain over the ear, this sort of area. It's known as a psychomotor seizure as well. And why psychomotor? Because psycho affecting the mind and motor affecting the body. In other words, it could be a mixed pattern seizure, and so the modern term is a complex partial seizure. It doesn't affect the whole body like a grand mal seizure, but it does a number of things. And so it can produce disturbance of thinking and make people behave strangely, so they're thinking the wrong thing and they'll carry out an action that is related to what's going on in their brain. And I had a young lady who was apparently throwing stones at a neighbor's roof. And so the police were called and the young lady was taken to the emergency department and referred to the psychiatry department. Well, in the psychiatry department, she had a series of more complex seizures. And the doctor there, the very brilliant Dr. Ermin Bell, recognized what might be going on. And she said, this patient needs to see Professor Fraser. So over she came to my outpatient clinic one Friday afternoon, and I heard the story of this lady. This lady was having complex partial seizures, and she was imagining, her brain was telling her that her neighbor was her enemy, and she must throw stones. And she said, I didn't understand why I had to do it, but I just had to do it. And I went out of the house and I picked up these stones and I threw them. And she was completely out of control. And there's a medication that's just perfect for that. And so introducing that medication and measuring the level in her blood on a couple of occasions, that lady's problem was completely solved. And that's the kind of very satisfying problem. And then there was another very famous Barbadian, whose name I probably shouldn't call, but it illustrates the value of a careful clinical examination and the skills that our medical faculty concentrates on in training our students. Now, in America, by the turn of the century, 2000, when a patient went to a doctor, there would be a quick history, maybe a cursory examination, and they'd be sent off for a long list of tests. And if there was any slightest indication for it, there'd be a CAT scan or MRI, and they would spend thousands of dollars. We don't believe in that because everybody cannot afford those thousands of dollars. Every patient is not being treated for free at the hospital, and in places like Guyana and the Outback and Jamaica in the country hospitals, you don't have that technology. So in our medical faculty, we train people to take a careful history, and the careful history will make a diagnosis in 80 to 90% of the time. Examine for the things that you might miss, because the examination of a patient's tummy or heart can turn up something really strange. Well, this goodly gentleman was brought to me because he was losing his memory, and he was talking nonsense to his son. So his son called me up and said, Henry, I'm really sorry to bother you on a Saturday morning, but Dad is not making sense. I saw him on Tuesday, and this morning when I came to check up on him, things just weren't right, and I'm very, very worried. So this was a Saturday morning when I had already gone into the hospital and done my early morning round, and I was now back home at 11 o'clock. I went down and I saw this goodly gentleman. And when I took the history, about 4 to 5 weeks before, he had had a car accident. He had had perhaps one drink too much, and he'd lost control of his car at night, which is very easy to do. Maybe there was a ZR van or a pickup truck which wouldn't dip their lights. He couldn't see where he was going, and he went bam into a guard wall on the side of the road. His head went forward and he hit his head on the steering wheel, and he was unconscious, he says, for he doesn't know how long. And when he came to himself, he had to go to the nearest house, which was about 300 yards away, and get a phone call to his son to come and sort him out. Anyway, he appeared to recover, and he was perfectly well for a month, and then everything was going bad. When I examined him, he had the neurological signs, which I will not bore listeners with, that indicated that that accident and the blow to his head had caused bleeding inside of his head, inside of his brain, right in front of his forehead. It was very clear from my clinical examination, nothing else, that he had blood right here. Now, in those days, we didn't have a CAT scan. This was the 1980s. Our CAT scanner was bought by Mr. Williams as a result of a gift by a wealthy Greek patient who had a villa in Barbados, and she wanted to help the hospital. And that was how we got our CAT scan. When Mr. Williams came to me and said, Henry, I got an offer of X $100,000. What should I do with it? And I said, we need a CAT scan. We've needed it for 10 years because the CAT scanner was introduced in Britain in the hospital where I worked at the Institute of Neurology back in 1972. And this was 1982 that we were being given this CAT scan finally. But just after this case occurred. And this case demonstrated the desperation of the need, because in those days all that we could do was an x-ray of the skull and see whether there was what we call midline shift. Well, a bleed here was not going to produce midline shift. So I had to call the surgeon, the late Frank Ward, with whom I had done my internship. Brilliant surgeon. He came, I demonstrated the physical signs, and he said, yes, I agree with you. And he ordered operating theatre right away. He went to theatre, did burr holes in the forehead, removed enough blood to relieve the pressure on the brain, and the patient recovered completely. It was a wonderfully satisfying case, because that was the most important man and one of my personal heroes as an elderly person who was cured as a result of a clinical examination without the modern equipment and a capable surgeon. Other reflections that I've had, which I've written about, include our own training at the University of the West Indies. You see, we in Barbados, for example, finally got a CAT scanner 10 years after I was working with the team at the Institute of Neurology on the first CAT scanner introduced to medical care in Britain, in London. And we finally got a CAT scanner here. In the past, we used to have to guess about what was going on in the skull. So in Barbados, where we have a CAT scanner and an MRI and a lot of sophisticated medical technology, now we are fairly well off. And so the bigger centres of Jamaica and Trinidad, they too are fairly well off. We know there's a new hospital in St. Lucia and in Antigua, but some of these areas do not have as many skills as the Caribbean should have. And so our students are trained with emphasis on their clinical skills. We like to think that a diagnosis can be made with a patient 80 to 90% of the time on the taking of a very good history. What's going on in the brain between the patient and the doctor. And in another 10%, the examination of the patient is absolutely critical. Because sometimes on the history you think one thing, but once the patient has removed clothes and you examine them, you discover something else. And in theory, doctors in Britain some 20, 25 years ago demonstrated that what the investigations did was to refine that diagnosis and in less than 10% create or find or identify a new diagnosis. And now, in most of the Caribbean and Guyana and so on, we don't have all the best technology. So our students need to be able to use their head, they need to be able to use their hands, and they need to have their heart in it. And so to use the old Fraser, Booker T. Washington, which the teacher Roald Parkinson so emphasized, a good doctor needs head, heart, and hands. In North America, it's quite different now. In North America, the legal profession has created a scenario whereby every patient practically has a whole wealth of costly investigations, often without the clinical examination even being done. Now, we can't afford that in the Caribbean, and in most of the Caribbean, we don't have that facility. So we have an opportunity, therefore, to market our medical school as a medical school training which gives students and graduates the skills that they might not otherwise have in more urban medical schools. And that's something that I'm very proud of. Now, people sometimes confuse the University of the West Indies with the offshore medical schools. There are a couple of offshore medical schools, especially St. George's in Grenada, which has made so much money that it has the best technology and it gets very bright students and it produces good graduates who will go back to the States. But they haven't had our hands-on exposure, which has been part of our training. So we are not an offshore school because we're not a school set up and financed out of the USA. We are primarily trained for Caribbean medicine. And our doctors will know much more about sickle cell disease, dengue fever, all the fevers caused by the mosquito, systemic lupus, which is more common in the Caribbean than in temperate countries. Our students, therefore, will know more about this than the students trained in New York or London. They will have an orientation of that kind. And therefore, that will have an appeal to students from many other places, southern USA, southern Europe, Africa, South America, and so on. And this is something that we should be marketing. And we still have a problem with the marketing of our medical faculty and the marketing of our university. Professor Nigel Harris once said that the UWI should be the first stop for everyone who wants any information on the Caribbean. and it should be the first stop, and it should be hugely competitive to get into our medical school for the kind of training that we provide that would be beneficial for everyone between the tropics of Cancer and Capricorn. And so I'm very pleased to hear that through Dr. Kenneth Connell and our current Vice Chancellor and others that we are developing a relationship with Ghana for training of medical students from Ghana. That is something that would be very valuable. So these are some of the things that I think are important. The last meditation, if you like, is on the issue of partnerships. I've said that partnerships have motivated me, and partnerships have been the answer to most of the challenges that I have had in running the Chronic Disease Research Centre and in running the medical faculty. These were huge jobs. Very few people have done both of these things, and I've been able to actually do both of them at the same time, as well as develop a full faculty. But it's the partnerships that were important. The partnership with Mr. Lionel Weeks in getting the site for the Chronic Disease Research Centre, the partnership with government on the whole in the arrangements between the university and government, getting, for example, what is now called the Errol Walron Clinical Skills Centre. That centre was abandoned by the government in the middle of the 1990s. And when I became dean, I said, we have to have that building. That building was a gift of Henry and Annie Nightingale to the government of Barbados, and it was used to build a hostel for the nurses, because in the old days, you know, in the 1930s, when that was built, the nurses could not be married and they had to live close to the hospital. So they had to live in awful accommodation, and that centre was built with its 60 beautiful rooms and large rooms for social engagement and so on. And it was abandoned because it hadn't been maintained. The electricity had never been changed since it was rewired with those external wires back in the 1920s. Roofs were leaking and so on. And therefore getting that centre restored as a clinical skills complex was something that I was extremely pleased with. And I negotiated that with Minister Jerome Walcott when he was Minister of Health. And I finally then got him and the principal, Professor Beckles, to sit together and agree on the terms of the peppercorn rent. I forget whether it was $1 a year or what, so that the university could get that building and restore it. And restore it absolutely beautifully, so that we now have a state-of-the-art library, common rooms, and all the facilities for our medical students as a clinical skills centre, because it requires laboratories for clinical skills training with instruments and models, you know. In the old days, if you had a lumbar puncture, it might be done with someone who'd never done one before. And we now have the facility for training people on models, how to do a lumbar puncture or spinal tap if you have meningitis. So those are important things that we have achieved. And I'm very pleased, therefore, even though I'm no longer involved, it gives me a sense of pride to see what we have achieved and to know that it has been a success story. What I would like to see is more success stories, because I'd like to see more partnership. I'd like to see ministries of health continuing the close relationship that they now have with the university public health people in doing the things that a university and a government should do for the benefit of the people through partnership. So my magic word is partnership, partnership, partnership.
A call for greater partnership as we work towards improving our quality of patient care and ensuring greater collaborative efforts between stakeholders in the healthcare sector, all leading towards greater success stories. This has been Sir Henry Fraser, His Life in Focus. I'm Miles Eversley. Do take care, and thanks for your time.